Hi everyone, just thought I'd do a quick video on how I like to do my mandibular blocks. I found a wedget that looks exactly like what the nerve would look like entering into the mandibular frame in here, you know, and I've always found that my blocks, especially after dental school or even during dental school, I always had trouble and I always felt like I had bone contact, but I was probably hitting this lingula. And so my blocks weren't always that effective. Like they'd be numb or tingling on the lip. They would say they're numb, and then you would drill and they feel it, and then you do another block. So it's like a whole thing. And this technique that I'm about to use has really helped me in my career because I've tried the gout gaze and it works really well, except on patients that are really tall and have larger mandibles, because then you might actually hub out with the needle before you actually hit bone contact. So you don't want to do that. So I found that this technique works pretty well because it acts faster than gout gaze, but it's also more effective than the standard block. So here we go. As a right-handed provider, I usually approach from the contralateral canine here, and I'm aiming for my index finger. So I'm stacking my three fingers, starting at the angle of the mandible, stacking them up along the ramus here, and I'm going posteriorly, superiorly, and laterally, and we're going towards hitting bone contact, but I'm trying to put my fingers together, or at least the needle towards my left index finger here, and then before I can do that, I actually hit bone. And this is where I would then, retract, aspirate, and then inject, and this would get pretty effective most of the time. If the patient's a little bit more jumpy, then I would actually deposit anesthetic as I'm going and inserting. I would actually rotate my needle, not like in on this model here, but I would rotate my needle, and then as I'm going, it actually starts to get towards the bone, and then after I check and aspirate and then deposit the anesthetic, if the patient's jumpy, I would have been depositing as I was approaching the bone contact. And then I would go back in with a second injection, but this time I can actually go a lot quicker because they're already numb along the path. And as a result, they get pretty numb. The Normally, if you were going to go for the gout gates, you'd be going up here towards the condyle, and then you would retract a little bit and then do your deposit. But again, if the patient is a lot larger, so a much larger mandible, you're most likely going to run out of room, and your needle won't actually reach it because you're going to hit the hub. If you're going to be doing this on the contralateral side with as a right-handed provider, I would actually stack my fingers this way. So my index is at the angle, and then my ring fingers at the ramus here. And I'm approaching again from the canine, the contralateral canine, and I'm going to be approaching it here. And as I'm getting in, I'm actually going to hit right about here. I'm aiming for the middle of my ring finger most of the time, but depending on the patient, like you might actually be aiming a little bit higher, more superiorly, because they might be a smaller patient, or if they are a larger patient, then you might actually be aiming for the middle or the lower part of your ring finger here, just because you might hub out. And so with patients like that, you would definitely want to ask them to open a lot bigger, because then you'll move the condyle or the ramus and the mandible a little bit more anteriorly, so then the tissue doesn't make you hub out on your syringe. I hope this is helpful, and give it a try and let me know how it goes.